All right, everybody. Thanks so much for being here this evening. This is our information session with Johnson Wales University's PA program. I am joined here tonight by Dr. Meehan from Johnson Wales, as well as Katie Spoladoro, who is the admissions coordinator extraordinaire at the PA program. Giving some information tonight. I'm going to let Dr. Meehan take it away and answer any questions that you have throughout the time. Please feel free to put those in the chat and we'll get those questions answered for you. So Dr. Meehan, please take it away. Thanks so
All right,
much.
thanks. So this is, I always have this picture of the front. This is kind of this is the current first year class of the PA program out in front of the building on day one of orientation. This is one of my favorite days of the year because it's always exciting to bring a new class in, but it's always fun to have them come in. So when I give these, I'm going to go through this kind of quick, but I want to make sure everyone understands what the profession is because this is something you want to do. It's a great profession. And there's some things to think about. So it was originally started because of a shortage of primary care physicians. And if you know anything about healthcare today, we're basically in the same boat as we were back then. But it was started for that reason. And so PAs now they'll work in much more than primary care. So it started by Dr. Eugene Stead at Duke University in the 60s. So the profession is now more than 50 years old. So it started with just former military corpsmen who had some medical training during their military service, and it was thought that they could then provide good patient care. So the first groups, the first half dozen classes, kind of came from that, but then now it's expanded on from there to anybody with any healthcare. Fast forward, and now we are nationally we're known as actually physician associates. This is something the American Academy of Physician Associates (AAPA) voted on during the pandemic. I was on the House of Delegates when that was voted on in 2020, and it's filtering down through the states. Rhode Island is getting there. We're considering it at the state level, but we still have to use the title physician assistant until it's in the relevant laws. But the important part about it is you graduate from accredited PA program, you're nationally certified, and the most important thing is you're state licensed to practice medicine. This is not a state license or certification or a certificate or ability. You are licensed to practice medicine with all those responsibilities that come with that. Historically, we think of PA as underneath the supervision of a physician. But now we're really much more of a collaborative approach. Most PAs don't necessarily even interact with their collaborative physician on a daily basis even. They have their own patient panels and they do their own work. And the other part of that is 20 years ago, most physicians owned their own practices. Now most physicians work for hospital systems or bigger groups. And so you don't necessarily even have a direct relationship with one individual. You have a relationship with an entire group, entire hospital staff that you work with. Still, classically, you somewhat follow the physician's scope of practice. So scope of practice in Rhode Island is determined at the practice level. But if I'm practicing, I've done most of my work in orthopedics. If I'm working in orthopedics, I'm not really treating somebody's diabetes, right? That's not my role as an orthopedic PA to do that. I'm going to leave that to their primary care physician to manage. It doesn't mean I can't, help out and manage it when they're in the hospital, but it's best done by those that are experts in that. My focus is, on orthopedic surgery. So from those few three, we're now up to 178,000 nationally certified PAs, which is roughly about 53 PAs per 100,000 population. If you think about the growth of the profession, this is why the profession is so exciting to be part of. Just from 2013 to 2023, we had an 87% growth rate. The Bureau of Labor Statistics keeps just putting out there's going to be a 31% growth rate over the next 10 years. They keep saying that, and basically we hit that by the 5-year mark each time. And so even from 2018, we have a 36% growth rate. In addition, the U.S. News and World Report reports this is as one of the top 3 jobs, period, not healthcare jobs, period, overall. And the reason is there's jobs available. It's reasonable to get the master's degree in 2 years, or a little bit more than 2 years for some programs, and come out, with this great profession that allows you to practice medicine without the long road of medical school as well, but still having a lot of the same duties of prescribing and diagnosing patients. So where are we in Rhode Island? We're up to 618 certified PAs, and there's about, last check, like 800 licensed PAs. So the 618 certified PAs, that's just based on their home address. We have some that live in Massachusetts, but they practice in Rhode Island, so that's where our numbers are a little bit different. Since the PA program at Johnson Wales is 10 years old, we opened in 2014. There were 300 certified PAs, so we've doubled the number. We're partially responsible for that. Not all of those 318 are from us, but we certainly brought PA into the fold in the state at a higher level. And you can see the other New England states. Massachusetts is a pretty heavy user, as is Connecticut, with decent numbers of PAs. I like to talk about the demographics of the profession and kind of what people go into. So currently it's about 71% female, but the median age is still young. So we have very few people that are retiring in a given year. Less than 5% of the PA population actually retires in a given year, and most of the PAs are less than 40 years of age. And when you look at PAs longitudinally, that shows it's such a great profession. You look 20 years out from graduation, more than 95% of PAs are still practicing, and that's just amazing that they get enjoyment out of that, fulfillment out of it, and this is what to go into. The profession is not as diverse as we should be, or that even matches the population. It is something that's a focus of our program as well as other programs to make sure we're bringing this profession to as a valid profession to all comers that are interested in it. When we look at where PAs practice, only 22% practice in primary care. So remember, I said we still have this primary care crisis. We'll talk about it in a second, why that is. But nationally, this continues to go down. Rhode Island's actually increasing in the use of primary care. We do talk to our students a lot about using primary care as an option. Where other PAs practice that aren't in primary care? Surgical subspecialties, can't say much different. I was in orthopedic surgery, CT surgery, neurosurgery. 10% or so nationally, this is national data, practice in emergency medicine, then internal medicine subspecialties. So you might practice cardiology, GI, gastroenterology, oncology, endocrinology, any place basically where there's a physician doing the job, you can pretty much have a PA practicing. The only two exceptions are it's really tough to break into anesthesia because there's certified nurse anesthetists that have kind of taken that role in. And there's not a whole lot of work in like direct radiology, just reading that, but PAs are in interventional radiology, which means you use imaging to guide where you might do an injection, do shots, or do other things. There's plenty of PAs working in interventional radiology. That can be for biopsying, a liver mass or something like that. You don't do that with an open surgery. You actually do that with interventional radiology to use radiology to find that mass and then do a of it directly through the skin. PAs are definitely doing that and doing those procedures. So some of the reason why we end up with PAs practicing in these specialties is they pay the most. And when you consider that the average national undergrad and grad debt for PAs is around $121,000, you want to pay that off as fast as you can. You're going to potentially take a position that's going to pay more. So a lot of the things that can alleviate this are things I work on with the state, with some state organizations in Rhode Island to look at bringing more PAs into family medicine, internal medicine, general pediatrics, is loan repayment programs, different scholarships, different avenues, so that it drops this $120,000 to a more manageable number. And then when you get paid a little bit less than your other colleagues, you don't feel like it's a burden in that sense. All right, so how do you become a PA? It requires an undergraduate degree. So you're in the right place. You or I get an undergraduate degree. Doesn't matter. We'll talk about it. Doesn't matter what profession or what major you're in. I'm sorry. Then you have to graduate from an accredited PA program, which we are. ARC-PA is our accreditors. PAEA is the PA Education Association. They're the ones that work with programs to make sure we're meeting our standards, but also aiding us with CASPAs put on by them, for instance, and several other things. You have to pass the National Certification Exam, the PANCE, which is put on by NCCPA, and then you get a job, and advocacy is done through AAPA. And then AAPA has state chapters. We have a Rhode Island Academy of Physician Assistants. that work on state legislation as well as support the national. So I mentioned before, one of the reasons why PA is such a good profession for a lot of folks is really just comes down to the time. Um, both PA and MD have 4 years of undergrad. PA schools range from 2 to 2.5 years. We're right at 24 months, so we're right on the shorter end of that range. Whereas med school is 4 years. There are optional 1-year residencies, but you don't have to. Whereas an MD, you have to have a 3 to 6 year residency plus fellowship. You might have a long time before you're actually out practicing fully. You are practicing as soon as you graduate med school, but underneath a lot of as part of the residency program. And the biggest difference is once you choose a residency as a physician, once you choose your area of medicine, it is really hard to switch. You might have to go back and do residency again. You might have to go back to fellowships, and so you're kind of once an emergency medicine physician, always an emergency medicine physician is kind of how it goes. Whereas in PA, you can change specialties. I always say it is if I wanted to practice pediatrics tomorrow, all I would have to do is talk to a practice that's hiring somebody for a PA for pediatrics, and I can practice in pediatrics. It just is, it's dependent on where the job is, but I don't have to have any additional specialty training because I'm generally certified and generally trained. So that continues. Yes, I mean, practices want you to have experience in their specialty before they hire you. If you're going to go work at Rhode Island Hospital in the level 1 trauma center, they're going to want you to have emergency medicine experience. They're not going to want you coming from a pediatric practice without getting any experience. You'll probably have to go someplace and do some urgent care other things first. But it's still, you have that ability to change specialties. Is very. All right, so a little bit about the Johnson & Wales program. Johnson & Wales in general, university is 110 plus years old. Started as more secretarial. Everyone probably knows this for culinary and hospitality, and that's what we were until really about 2014 when the PA program started. So we're 10 years old as a PA program. Since the PA program has started, the university's added a BS in biology, health science, public health. They have an advanced bachelor's of science in nursing, another great way into medicine. It's a little different than PA because it's the nursing level, but sometimes that stepwise fashion is great for some folks, and it really requires a lot of the same prerequisites. So it's a good way into advanced medicine as well. And then most exciting thing is in the College of Health and Wellness now, we have occupational therapy doctorate. We have a master's in public health, a doctorate in physical therapy, master's in dietetics and applied nutrition. So that allows us to have our PA students work with other students in other professions to work on the team-based aspect of medicine. Medicine is not an individual thing. I don't go out there and treat someone all by myself. I might treat them in orthopedic surgery. I might prescribe things, but I might then send them to physical therapy or occupational therapy to take care of their additional rehab needs. I'm not the one doing the rehab. I'm not the one doing their dietetics, the dietary needs they have. So it's important to understand what the scope is of all providers, but we have that within in-house. It's really exciting with the nursing program as well. So the PA program is accredited. Our next accreditation visit is in 2027, so it's starting to get there, getting close to us, but this is something I do all the time. So we have the continued accreditation status as well. So the focus of our program has always been on really patient-centered humanistic healthcare. And this really stems from the Arnold P. Gold Foundation, started in the 1970s and 80s, realizing that medicine was becoming all about the tests, all about the imaging, all about this, and not actually about patient interaction. And so they created the Arnold P. Gold Foundation to really bring that care back into healthcare, and empathy, trust, respect, and really that patient-centered care that is critical. So yes, you can understand the best medicine that might be needed by that patient, but you need to understand where the patient is in their life and where their ability to to take that medication, afford that medication, or other options. So this really has brought listening to the patient back in, and it's definitely a focus of how we kind of handle our humanistic principles. What else makes us special? We have a whole building, 14,000 plus square foot building dedicated to PA studies. So we have our classrooms, we have our cadaver lab, and other things we'll talk about. We have an affiliation with the Warren Albert Brown Medical School, which is 3.5 blocks away from our building. So we go over there and do simulated patient encounters. We We have a lot of good relationships with physicians and faculty at Brown that come over and teach on their specialties. We have the emphasis on humanistic principles, as I mentioned. We have experienced faculty across all areas of clinical practice that lead you in learning their area of practice. And when we don't have that current practice experience, that's where we get those adjunct lecturers from Brown and from the medical community to come in and talk about their specialty. And so we can have the best of both worlds. We have a robust faculty, and we're continuing to add to this faculty. Kind of divided into a didactic team and clinical team. Didactic team, this is the one that coordinates everything in that first year of the program. Look at the curriculum, and the clinical team are the ones that really go through and coordinate the second year, which is your clinical practical rotation year. So this is the outside of our building, but some of the things we have in the building, and we just recently upgraded our technology within the classrooms. So we have active learning classrooms, we have lecture capture capabilities. We understand that the lectures are going really fast and you can't always write everything down. So you have the ability to do lecture capture. We have cadaver-based anatomy. So every summer we get in new cadavers. We have a 6-to-1 student to cadaver ratio in our labs in the summer. We have a clinical skills suite, which mimics more like a hospital emergency room, but it has 12 beds around the room where you learn that hands-on patient-centered care that we talk about. And then we have a lot of study space and lots of just extra space for students so that they can come make this their home while they're in class, and even nights and weekends. I guarantee students are there right now. Studying GI is what they're in right now, so I'm sure they're in there. What else makes us strong is we have a really strong track record over the 10 years. We've never dropped below 94% in any one year, and our 5-year pass rate is 98%. Well, that's great. Yeah, okay, we're good at that, but there's 2 ways to get that pass rate. One is to just only graduate students that you know are going to pass, but we also have a very supportive culture leading to a strong on-time graduation rate. We're at 96%. So in the last 5 years, 180 students started the program and 173 finished on time, which means within the 2 years of the program. So we bring students in that are capable of doing it, and then we support them along the way to make sure they're able to do it. So we have a lot of different supports and tutorings and faculty support and wellness that we embed in our curriculum to make sure students are able to do this strong program. All right, so the curriculum is a 24-month program, as I mentioned. 1 year is didactic and 1 year is the clinical year. Very strong foundation in basic medical science. We'll see that in the summer. So we believe that if you understand physiology and pathophysiology well, then you'll understand how to diagnose and treat these, because it's all there for you. We do a body system-based approach, and we'll talk about what that means, really an immersion into that system for a period of time. Then when we come to spring semester, we do problem-based learning as well, which helps you to learn, synthesize, apply those to case studies, because we, instead of just sending you out with all the knowledge, we want to make sure you understand how to actually apply that to patient care. And then the clinical year, as we'll talk about, has specialty tracks as well as the core rotations. So I'm not going to go in super detail on the curriculum. There'll be time for that when you come interview. Go through this in detail. We go through this in a lot of detail, so you know exactly what you're getting into. So our applied anatomy in the summer and patient care are both going on, and this is where we get that basic science. We're dissecting in the anatomy lab. And in patient care 1, you're learning how to do a physical exam. So if we're looking at the heart and lungs in the anatomy lab, you're listening to the heart and lungs in the patient care lab, and you're trying to see how those fit into your diagnostics. Foundations of Medicine is a basic science course with cell physiology, genetics, microimmunology, an intro to pharmacology, how are the drugs treated by the body. And then the bottom, we have the professional health policy issues course, which is really everything else that needs to be a PA. You have to know about health systems. You have to know about insurance. You have to know about how to get licensed, how to get certified, all those things. We cover all that in there in that course. Then we move into fall and spring. You can see the different body systems of the body, and they're given more time if they're bigger, like cardiology, a little less time if there's less conditions to go over, like hematology, right? So you're spent in there, you're immersed in there, you learn the advanced physiology, the pathophysiology, all the disease states. You learn the pharmacology that goes along with it. Any diagnostic tests or medicine that you need to do to get that is all covered in that period of time. And then we do continue to practice that patient care. So now instead of a generalized patient survey that you'll do in the summer, you'll come and you'll do a case-based. So somebody will show up with shortness of breath. You've got to actually go through a process of figuring out what that is in an efficient manner. We have our Intro to Evidence-Based Practice series, Intro to Evidence-Based Practice, then Problem-Based Learning, because as much as we teach you everything you need to know in those systems, by the time you graduate, it'll change. And medicine is constantly changing. So you have to know how to look at literature, to understand guidelines, and how to apply those to that. And then finally, in the didactic year, we wouldn't be Johnson & Wales if we didn't have food as medicine as part of our curriculum. So this is the dietetic faculty come in and teach about specific nutrition needs for different patient populations, such as Mediterranean diet, DASH diet. How is that helping that cardiology, patient that has hyperlipidemia? And then twice a semester, we go down to industrial kitchens and actually cook some recipes that go along with it. So students really enjoy that. It's not meant to be, you're not going to come out of here as a chef by any stretch of the imagination, but it is fun to go down there and cook it and realize that I can help patients in a different way. Give them ideas on how they can make the food still taste good without using all the salt that's going to cause their blood pressure to skyrocket, but they can still actually use other things to flavor the food as well. All right, so going on to the clinical year, we have 9 rotation blocks, 7 required rotations. These are required by our accreditors to make sure we're giving you that generalized education. You'll spend time in internal medicine, pediatric, women's health, family medicine, emergency medicine, behavioral health, and surgery. With each one of those core 7, there's a national end of rotation exam that's put on by the PA Education Association. So you're benchmarked against 10,000 PA students a year taking those exams. And so we really know that your knowledge base is good if you're passing those exams, and that you're prepared to go into clinical practice. We additionally have electives, 2 electives, which are of your choosing. Some people like to do another family medicine rotation if that's what they want to go into. So they can be back in a core rotation, or you can get into some of those specialties. Where our rotations, basically you put a pin on Johnson & Wales and Providence and draw a 45-mile circle. 95% of our rotations are within that 45-mile circle. So we don't have an expectation that you're going to get shipped someplace else, and that's not true of every PA program, to do a rotation and have to find housing in that other location. If you have housing in an area from outside of Rhode Island, then sometimes we'll work with you to see if we can get some rotations, usually electives, back near your hometown. But if someone, you guys are in North Kingstown, if someone stays living in North Kingstown when they come to the program, we try to put most of the rotations in Providence or South. If someone lives up towards Boston, we have some students that live in Taunton or something, and they come to the program, we're going to try to put their rotations in Fall River and up in those areas where they're a little bit closer. So we have rotations in Rhode Island, across the border in Massachusetts, Swansea, Seekonk, Fall River. We can get some rotations up in Boston. It's a very competitive environment. And then we have ones down in South County and all the way in a couple the border in Connecticut, both on the southern border and then on the border. So we have enough rotations, enough choices for that. We have a good mix of major medical centers where it's a good experience. It's the top of medicine in the area. But you also have residents, fellows, med students, nurse practitioner students, to compete for sometimes, on a rotation, time. And then we have the smaller community hospitals, Fall River, Landmark, where you might be the only PA with the surgeon, and you're in the operating room just with you, the surgeon, and the surgical tech. And that's a great experience as well, right? You're right in there versus kind of competing. So, any questions on the curriculum before I get into application? All right, not seeing any. I'll move on. All right, so application is really what you probably came in for, to figure out how to apply the program. So we do use CASPA. There are 310 PA programs. I think around 300 use CASPA, give or take. There's roughly 33,000 people that apply to PA school and roughly 12,000 that get in. So you're talking about a 40% success rate. Most people apply to multiple programs as well. The majors are across the board. Biology is 2-to-1 by far the highest, most common major used. But there is no requirements, as you'll see in ours, of a particular major. Biology majors tend to come from that, even from maybe being pre-med initially, or from that really basic science background, which it is a benefit to you as you go through, because you'll be able to understand the physiology a little bit better coming from that background. But definitely our health science and psych majors bring a different dynamic to our class. And they have the knowledge as well. Don't get me wrong, they learn the physiology, but they have that other benefit of having experience on the public health side, and that side that maybe gives them a little bit edge on some areas of PA practice. We offer 36 seats per year. That's our limit from our accreditors. Out of greater than 1,000 applications, really 1,200 is where we're kind of sitting right now. Cohort begins every June, end of May, for last couple of days of May for matriculation. The first Monday in June is day of class. We do rolling admissions starting late April, and we have a deadline of October 1st. I'll talk about the articulation agreement on the next slide. The articulation deadline is September 1st. We begin interviews late fall, late summer, early fall, usually either maybe one in August, but usually we really start full force in September, October as well. All right, so the articulation agreement. So this is a guaranteed interview. So we're not having to filter out through those 1,200 applications to find the ones we want to interview. We interview about 130 applications a year. We offer typically around a total each year is around 55 seats, because we have some people that decide not to come to us. And so I was talking to Ashley about a student from URI that applied the cycle that got in off our wait list, and she's very excited for them. I say, yeah, it's a struggle. It's not a struggle. It's just we only have 36 spots we can offer. And so there's going to be some time on the wait list, which is for about a third of our class. And that's fine. We make that very clear that it isn't an indication that we're not interested. It just means we have to, have that stopping point while we fill our class. So part of the articulation agreement is you get that guaranteed interview. So you jump right up into that top 10% of candidates if you meet these our enhanced admission requirements. So the cumulative and BCP. So BCP is a biology, chemistry, physics GPA. That's the one calculated by CASPA. So as you put all your science courses in, it's greater than a 3.5 for this enhanced. Our minimum criteria for applying to our program is 3.2. No prerequisite grade below a C. You have to have at least a C in each one. You do need to get a letter of recommendation from a science professor at URI as part of that, and Ashley has all this information. And then you do come and you participate in the interview like any other candidates. We do spread out the articulation agreement candidates to put you at a time when you're most likely to be successful. So we don't want you, being compared against candidates that aren't at the same level as you. So when we put you through, we put you at a time. So you might not get the first interview day, you might get the third, but you're at a time when you're really comparing better directly compared across that. All right, so what are the academic requirements we need? You have to have the bachelor's degree, which you'll get from URI. That minimum GPA, so that's 3.5 for the articulation candidate. We do not require GRE. Some programs is getting down to about a third of PA programs require GRE, but we don't require GRE anymore. We stopped it a number of years ago. We have prerequisite courses that we need you to take: 8 credits of biology, 3 credits of micro, 3 credits of genetics, 8 credits of chemistry with lab, anatomy and physiology, 8 credits with lab, either separate courses or combined course. Behavioral sciences, we're just down to 3 credits. Intro to psych or abnormal psych is where we kind of want you hitting. And then a college level math, stats, biostats is somewhat preferred over calculus. I mean, it's fine if calculus is what you have, just because when we get into literature, we're going to be thinking about biostat in that sense. We do not accept AP credit for prerequisite courses. So if you received, 4, 4 credits of chemistry from an AP exam, you would still have to take 8 credits at the undergraduate level. You can either be retaking those basic chemistry, or they can be organic or biochem or something above. We do recommend doing more than the minimum, basically, in the science coursework. We find students that come in with biochemistry, cell biology at a higher level, organic chemistry, are just better prepared for the curriculum. I mean, it better prepared for that fast pace of the summer. And so it is recommended. It's not required. The requirements are there. We definitely have students get in with those. But those upper levels, if we're choosing between 2 candidates, we might choose a candidate, 2 equivalent candidates. We might look at the one a little bit more favorably that has some of those upper level courses. So think about some of your electives, that you might take. Additional requirements: we do require patient care hours. We have a minimum of 250. It's not a lot. They do need to be direct hands-on patient care. Some of the examples we see: a certified nurse assistant, CNA, an EMT, medical technician, ER technician, scribe, MA. All these are good. We really have a broad definition. We do have a list on our webpage. But if you're taking care of patients, we generally accept it, because I look at patient care as benefiting you, not me. It's not going to help me if you have 30,000 hours. Doesn't make you qualified, and going to be a great PA. So it's as much for you to get into the healthcare setting and understand how you function in that system, and make sure it's something you like. It's not all great days in healthcare. Like, you're going to have hard days, and as you're doing that in healthcare, you can. The more hands-on patient care that you can have, the more hands-on it is, the priority that's given towards that. We have no minimum shadowing hours, other than, I guess, maybe 1 is a minimum, but virtual is definitely considered. Or if, as part of your direct patient care hours, you work directly with PAs, then we kind of understand that. We'll ask you about it if you haven't put it, but we'll say, okay, we understand that you have that direct patient care with PAs. And then 3 letters of recommendations, one of which does need to come from a science professor, or from through URI. All of this is submitted in CASPA. None of this is submitted directly to the program, even from URI. There's nothing. So if they do a composite recommendation, which I know some that they've done in the past or sometimes, that is submitted through CASPA, not submitted through directly to us. Let's see what else. In writing about your patient care hours, it's just a pro tip here. When you're writing about those, give detail in that detail area. So we can judge how your patient, how much patient care, direct patient care you have in there. So, for instance, somebody's a CNA, they work in a nursing home, and they give their details of their duties as standard CNA duties. I'm gonna look at that and go, okay, you didn't take the time to tell me what you did. But no, I did these things for the patient. I was the go-between between them and the nurse. So give some detail in there as well. In the regular CASPA requirements, there's certainly your personal statement. There's a why Johnson & Wales question, custom questions that come in there too. So those are still required and standard, but these are the specific requirements for the program. So just to give you an idea of where our students have what they've come in with. You can see the ranges below: the overall GPA, the BCP GPA. Just like all PA education, it's a competitive process. I do want to point out the patient care hours. We sometimes have, you can see in class 2025, we had someone with 30,000 patient care hours. That's not the norm, right? That's not, so it is a range. I find students coming directly out or with only 1 gap year are going to be the ones that are in that 700 to 1,000 range, and that's fine. Yes, 250 is the minimum. I still would say get as many as you can. I wouldn't just hit 250 and leave the job. Just because you met your minimum, because it's still, the more time you have, the better your patient care skills will become, the better you'll be ready for that. Where our demographics, we relative to the populations in the region, I think we do pretty well with underrepresented medicine, which kind of focuses on a broad category based on ethnicity. But what we're really actually are strong in and supportive of, and it goes back to our high graduation rate. We actually have first gen college hits actually pretty high within our program, and some of that support that we provide allows these students to be successful in the program. And I think that's something we're very proud of. We certainly recruit in lots of areas through affiliation agreements, through a program around medicine called Pathways to Medicine. So we spend most of our time working in underrepresented groups at the middle school and high school level, just for the overall benefit of the profession, not necessarily our institution. Just say that this is a valid profession to consider being part of. All right, so timeline. CASPA opens the end of April. If you are applying your senior year, do not submit in CASPA until your final transcripts are ready. Trust me, it'll save you a lot of time. If you're applying your junior year, then we'll get additional transcripts from you. And they can certainly be uploaded into CASPA. We'll get those additional transcripts if you're applying, before your senior year to start right after. Mentioned the application deadline, the rolling admissions, and then class start. I do want one real quick to talk about a plan. So you have to be thinking about, are you academically prepared? Is it better to review some materials? Do you have that strong science foundation? Are you financially prepared? Can you afford to do the practice type that you want? If you want family medicine, pediatrics, primary care, you're going to want to consider how you're going to pay for PA school. Are you personally prepared? Do you need a gap year? I would say, I was telling Ashley, only 25% or less of our students come right out of like a May graduation and come in. It's probably even closer to like 10%. Most students take 6 months, a year off, apply at the end of their senior year versus applying after. That gives you a chance to get a few more hours in patient care, get yourself in a better financial situation, so you're not relying too much on student loans, and then just be more mentally prepared. You compare it to med school where you're starting at med school at 22, 23, you're not practicing until 30 versus PA at 23, 24. If you come out of undergrad at 21, 22, at 24 years of age, you're practicing and licensed to practice medicine. And so yes, age is just a number. I always say the most mature person in my PA class, and I was 30 something at the time I went to PA school, and the least mature were both 21. So it didn't matter. But I understand that, but just think about those things. If you have anything you have to take care of, animals, people, you're the primary caregiver for, and helping out with a parent or grandparents or anything like that. Somebody else has to take those responsibilities on when you're in PA school, because our class days are from 8 to 4, and then on rotation you work a 40 plus hour week, whatever the hours are for that site. So emergency medicine, that can be overnight. Pediatrics is going to be more 8:30 to 5 or 8:30 to 4, but with these others. Then when we get to the point of matriculating, it's always important to consider keeping up with your vaccinations and titers to go along with that. We do national criminal background checks, and that's required by our affiliation groups to the hospitals, but it's also required that if we're going to graduate you have to be eligible to apply and be certified by Medicare, Medicaid, private insurers, and there are things in a criminal background that would prevent you from being able to actually be licensed even. And so we want to know that in advance. We have technical standards that you have to meet. We have a great accommodations department, but these are things that we feel like are important to do that. And then basic life support certification. If you want to come see the building, Wednesday, April 23rd, we're going to hold an open house. Fortunately, you have to sit through this presentation again. It's mostly the same slides, probably the exact same slides. But you get to then tour the building, talk to students, and talk to other faculty members that'll be there that evening. So that's at 6:30 at night. So we try to do it late enough that folks can travel to it, after the regular day. And finally, anything admissions, talk to Katie. She's definitely able to provide any information, or for you guys go through Ashley as well, and she'll answer those questions. Sometimes it's, will this class count? It's not exactly a standard bio or something like that, and we work through and we look at. Sometimes we'll ask for the syllabus and say, yeah, that's good. Or, hey, my bio didn't have a lab, but I did a summer of lab work. Then oftentimes we'll, if you had course credit for that and things like that, we can work on that. All right, I keep this slide in there. This is actually the original cohort back in 2014 on, again, their first day of orientation. This is the upstairs. This is really that student area. There's this large area behind this door over here is a library, seating area, plus a big conference room behind it. And then over to the right of this picture, there's 2 student conference rooms. Then down the hall here, next to clinical skills, there's a small kitchenette with microwaves and refrigerators. And then there's locker rooms because we're going to go into the anatomy lab and use cadavers. So we want to be able to change. We need to care. So we kind of have all that in the upstairs section of the program. So with that, I'll take questions.
If you have questions, you can feel free to unmute or you can put them in the chat. Dr. Mean, I have a question about, let's say, a student who might not have performed as well as they were hoping in undergrad and are moving into doing more of a master's program to help improve their GPA before applying for a PA program. Would you consider anything in particular, in maybe that's a Master of Science would be better than a Master of Public Health or something along those lines? And with that, would anything in terms of online programs be acceptable or not really considered as great experience?
Yeah, so a couple of things with that. So, if it's just 1 or 2 courses, then certainly retaking those courses, is a viable option. PASPA, when they calculate, every time you take the course, it's there, so it doesn't replace a grade. They don't have a system in there set up to, if you take a course again, that it replaces the grade. The original grade is still there. I find it very difficult sometimes to move GPAs, especially at the end of the hours. I would think something that is going to get you more into healthcare and doing work at the graduate level is ideal. The 1-year master's in medical science, I think you'd want to do that with the idea that if you didn't ultimately go into PA school, that would be a value add to you. Johnson Wales has started a public health program. We are working on agreements internally with them that students will apply to that program and then have an internal leg up to get into the PA program if they're successful in that program, so they could kind of have a tryout. But if you just graduated with the public health degree, there are jobs there for you. So I'm not a big fan of these 1-year, spend $60,000 on a 1-year, master's in medical science. That doesn't necessarily move your GPA all that much. Yes, you demonstrate the ability to do the work, which is good, but it's really an individual question as well. And I mentioned earlier, sometimes if practicing medicine is where you want to be, then the consideration of that kind of advanced bachelor's in nursing route, 16 months you're a nurse, and then you're ready to go. You could do the NP route, and at the end of the day, NP and PA really practice very similarly in most states. Rhode Island's no different. So there are other routes to get to that kind of stepwise fashion into it. That brings it along. So we are also looking at in the future doing a dual degree with an MPH PA, where they do the MPH first, but that's not it's not currently there yet. But functionally, the MPH program has a 1-year track starting next summer, and so it is starting this summer. that in 2025, that is an opportunity. And then by the time this cycle comes around, we will have some language on our webpage about not really a dual program yet, but certainly that a pathway into the PA program is through that 1 year MPH program. So be on the lookout for that if someone sometimes affiliating with the school and getting in and still getting that master's of public health can be. That being said, if you went on someplace else and got a master's of public health, went on your ability to use the affiliation agreement does not sunset at all. If you take your gap years, so those that might fear like I have to use it when I'm a senior, or else I can't use it. That's not the case. It is only available for one time, so one interview. So we do if you're thinking that, oh, I'm just going to apply this time just to see, just get my feet wet, and but I really actually was going to wait a year, then I would say just wait a year to use the affiliation agreement. You certainly are welcome to apply through and not use the affiliation agreement and then use it another year. But I would say that'd be my recommendation is to go ahead and use it. But if you come Johnson Wales MPH and you still have the URI, I mean, you're getting kind of dual into affiliation agreements potentially through that process. So that's what I would say.
Great, thank you. So some questions in the chat. The first one here, do you count hospital volunteering as patient care experience?
Not the pure volunteering as in just, sitting at a volunteer desk and transporting patients. No, because that's not patient care. It does not have to be a paid position, but it does have to involve direct patient care. Whereas a lot of volunteer opportunities at hospital, which are great, I think they're still great to do, and show that you're really engaged in the healthcare system. They would not be considered patient.
Great.
So it does depend on the position. It can be a volunteer position as long as it involves actual patient care. It does not have to be paid. It could be, we have people that volunteer at the Rhode Island Free Clinic as MAs. That absolutely counts as patient care because they're actually doing patient care. But it's a volunteer position. It's not a paid position.
So I'm hearing, Dr. Meehan, that it sounds it's much more the title and what you're doing versus if it's a volunteer versus an internship.
Correct, and the details of what you're doing. There's two places on CASPA that people put their patient care hours. There's this health-related experiences. Some people feel like if I'm a scribe, I put it there as opposed to patient care. Anything that involves working directly with patients, even as a scribe, which I know is a borderline, but we do accept it. Put that in patient care hours, because what happens is if it goes in the health-related, when we're calculating things, it doesn't get tabulated properly in our system. So put things in patient care if they involve patient care. And then if we see something in there that we're like, oh, that's not patient care, we'll just subtract numbers. It's easier for us to do that than for you to miss out on getting credited with something.
Great, thank you. One question from Susan about offering teaching or research assistantships.
Do you mean during PA school? Like, is that what you mean? Your PA school and there's yeah. You do some research, although it's more evidence-based medicine research as part of your master's project and the master's part of the curriculum. We do have students that have more research interests that have gone on to use that portion of their time for that. We're working on two things under electives. One would be a research elective, instead of doing an additional clinical elective, but a research elective, and the other is a faculty elective, basically where you do some teaching, you do some things alongside a faculty. And then the third thing that we're starting to pilot is we do take a recent grad and they do work in a teaching role the summer after they graduate. Dirty little secret about graduating as a PA graduate is it takes 3 to 6 months to get licensed and credentialed and start working. And so you come out of school and need something. So So to be able to jump in and help out. So those are definitely things we have interest in using our most recent grads in that, really in that summer semester after they those are all things that we're definitely interested in, because we know that good faculty in the future come from students that have interest, right? Students do we do students, second year students, clinical year students do act as the tutors for the first year students. We identify a couple that have interest in it, and they do function in that role as well. So there's that teaching side of it that goes along just at the tutoring level, but those also tend to be the people who go on, a few years down the road and want to become a faculty member. So, yeah, good question.
We have one question from Lindsay talking a little bit more about what the problem-based learning looks like as part of the curriculum.
Okay. I see the question about internship count towards patient care hours. As long as it is in a role that's taking care of patients, yes. If it's more shadowing, if it's a shadowing internship or something like that. So, yeah. So what does problem-based learning look like? So within each body system, we're focused on cardiology, for instance, and you're in this really 4+ weeks of cardiology, and that's all you're focused on. So if I give you a patient that comes in with chest pain, what do you think your disease states that you're going to think about are? They're all going to be cardiology, right? That's not the reality of medicine. Somebody comes in with chest pain, they could have a lung issue, they could have a musculoskeletal issue, they could have cardiology, of course. They could have hyperthyroid, and it's all going to present as chest pain. So the problem-based learning course is 12 cases. Every student goes through all the cases with a faculty member in small groups of 6. You walk through all 12 cases, and these cases cross systems, and the faculty member stays with their case. So you go to the different faculty members to get their expertise. So we'll do a case that might start off as shortness of breath, and it might end up being a pulmonary embolism, and that pulmonary embolism then leads to the patient actually having a clotting disorder. And so you're working through the problem, but patients don't come in saying, I have this disease. They come in with a problem. And so it really helped get that critical thinking that's necessary for proper patient care. So our general curriculum, though, so there are programs that are problem-based learning, and that you do like anatomy in the summer, and then you start the fall, and you basically start with a patient that's shortness of breath. You've got to go through and learn cardiology and pulmonary on your own in that problem-based learning. That's not what we are. We are a lecture-based curriculum with case studies throughout, and certainly hands-on, work through those cases, and so you understand how to take that patient care. But we are not like that pure problem-based learning, but our problem-based learning course, as we go through, allows us to ensure that you have that critical thinking across systems.
Lots of questions about patient care experience, Dr. Meehan, rehabilitation aid, or like some examples of patient care experience when looking through applications, any that particularly stand out. I know you had listed some on the slide, and I believe you had mentioned that they're on the website as well. But we know medical assistant is a great example, rehabilitation aid, if that would fall into that category, or some suggestions. And Katie, you might want to chime in here as well in terms of what you see in applications that kind of stand out for patient care experience, if any.
Yeah, all of these, are a PT aid, outpatient physical therapy office, rehabilitation aid. Yeah, you're directly taking care of patients. I do recommend people to get a variety of settings. So even someone that's a scribe in the emergency room, I usually recommend them trying to see if they can scribe in an office setting, because medicine's different in those facilities. If somebody is a pharmacy tech, I kind of recommend, maybe you need to get into, it's fine. That's acceptable. That is, still considered patient care hours, because you do care for patients as far as, on the pharmacy side. But I certainly recommend a variety of experiences can be good as well. And so thinking of other things, it comes down to how much decision making do you have in the patient care as well. Thinking about something where you're really the one that's in charge of it. And not to say everyone's going to become an EMT or something like that, but when you're an EMT, you're really responsible for that patient in your setting, and there's nobody standing there. Whereas, in the example of rehab aid, you have the physical therapist that's there, that's really, responsible for that patient. So there's different critical thinking skills that are needed for those roles.
I agree with that. I usually say the more hands-on, the better. You want to make sure your application is as strong as possible just because the PA program is so competitive. We listed a lot of good ones there. There are many that we don't. Babysitting is not acceptable. Sometimes people do ask that. Camp counselor, although sometimes camp counselors, if you're a medical assistant at a camp counselor, that's fine. We say medical assistant is a great one as long as it's the back of the house and you're working with the patients, casting, suturing, splinting, removing. There's just so many examples out there. The more hands-on, the stronger your application will be.
Yeah, like a receptionist at the front desk is not really patient care, right? That,
No.
so that's not really doing it. So I see the question about liking seeing physician associate or physician assistant. Both are good. The one thing that you want to make sure your spell check didn't do is put an apostrophe S on the physician. That we don't like to see, whether it's physician's associate or physician's assistant. No, we don't belong to anybody. That we don't like to see. So just in it, I know nobody is intentionally doing it, but as we know with not even using ChatGPT, you're not technically allowed to use that in your application. But even just typing along in Word, it's going to autocorrect, right, for you, and you don't catch it. So proof it, autocorrect it. Look for those autocorrect because it'll do it the first couple of times, and they'll realize, oh, they don't want me to do this anymore. So yeah, physician associate does show that you're at least up on the current, but it doesn't. I don't look at it and go, oh, well, that's definitely a great candidate because they know which one it is. And somebody puts physician assistant, well, that's really what the profession still is. So, especially in the state of Rhode Island. So until we change that, but even if someone, 5 years down the road, we've changed it in Rhode Island and changed the name of our program, and someone puts assistant, I'm not going to like either, because I understand that's what the profession has been for so long.
I posted on the top of the page in the chat just a link to some upcoming graduate events. So if people are interested in other programs like the OTD, DPT, the second degree, the ABSN, the second degree in nursing, the links are all there. In addition to this, Tom, I didn't tell you this, I apologize in advance, but we're also hosting an open house, a graduate open house on April 5th. It's a Saturday. Signups will be on Gaby Commons, and then we'll be splitting off into groups, and each graduate program will have faculty participating to do a quick presentation and a tour of the building. So you can check through that page, see if there's anything you're interested in, and we'd love to have you on campus. In addition to the open house that we will be having specifically at the PA Center, you'll be just joining us directly there. So there'll be 2 events in April for you. I guess we'll talk about that tomorrow, Tom.
I'll find someone to do it.
I just had a quick question. So I was wondering if you had any recommendations on what to put in a personal statement and things that you like to see highlighted in applications for that.
Yeah, I think that's an excellent question. So it's, the prompt is, why do you want to become a PA? Right. So there's 2 parts to that, right? You want to be in medicine. So you want to make, why is it that you want to be in medicine? What is it about medicine? Patient care, and I just like to help people is maybe not as strong as, you don't have to have a sad family story. That's not a requirement in reading a personal statement to align to that. Ever since then, I've wanted to do it. But the other side of it is making it clear that you understand what a PA is and what they can do. So weave in your patient care experiences to how that has informed you about the profession. That's critical to see. Because if I read 2 statements and somebody hardly even mentions the word PA, but they just talk about healthcare and wanting to be, helping people and be part of, patient care, that doesn't tell me they even know what a PA is supposed to do, or where a PA fits in all of healthcare. So including both aspects, I think, are important. Why you want healthcare, what you feel like, why you'll be strong in healthcare, but then what your patient care experiences, your shadowing, and other things have taught you about being a PA. And the understanding of it being, profession that is practicing medicine and the responsibilities and everything that comes along with that. When people convey that, in a statement, convey, what type, potentially what patient populations they want to be part of. We don't have a primary care mission in our program, so we accept people if they say they want to go practice orthopedic. Kind of hypocrite if I didn't, right? But so we absolutely, we read the personal statements, even though you get a direct interview, to the program. We still review your personal statements. We still review your why Johnson and Wales. Your why Johnson and Wales, shouldn't be because I'm in Rhode Island and there's affiliation. That's not a great reason. You should want to come to us regardless of these things. Like you need to make that emphasis of what is it about our program compared to the other PA programs that stands out to you that you want to come, and be part of the program. And so those are the two real opportunities to kind of stand out. There is an additional essay on CASPA that we look at sometimes. There's a life experiences essay now. I think they're going to require it this next cycle. And in future cycles, I think in the past it was an optional essay, and I think now it's required. Sometimes we can look in that. Maybe that's an opportunity to, to speak to, any issues with that you've had academically, and but your life experiences, have made you stronger with that. It's an opportunity to kind of speak to those things sometimes. And I know faculty, we don't specifically read it, but I know faculty sometimes if they're kind of torn on a candidate, they do want to go back and look at these other things. Recommendations. I know we mentioned the one recommendation that's always a question. You want someone that kind of knows you professionally. In your patient care is always a good person. Someone that can speak to your, potentially to your leadership is fine, to those abilities. What you don't want to do, and they're well-meaning, but it's somewhat gets ignored, is if the person says, I've known Jane since she was 3. That's not an objective evaluation at that point. You want to make sure that the person is going to actually write a letter. If they're strapped and they're going to write 3 sentences how they support your candidacy, that's also not a good letter, right? So because we didn't learn anything about you, in that letter. And there's times where I learn not more about the candidate, but some additional things that maybe you downplayed some volunteer or some different things but the letter recommendation glows about things that you did, for them or for the, so typically, we have the one, faculty science professor from you, but we also like to see, places that you worked with in healthcare. Shadowing is then a step below that, because in shadowing somebody for 8 hours, they don't really get to know you very well, right? Versus if you work with somebody for 1,000 hours, they're gonna pretty much know you. And if you're, running the office in the back and they say, we told them as soon as they graduate that they can come get a job here, then, then that's the kind of thing that, that.
Yeah, we like to say, choose somebody there are people that can write a letter, and then there are other people that can really write a letter and really show what you're all about and give us more history, and more importantly, let us get to know you. That's important. There are people that some candidates choose who write awful letters for them, terrible letters for them. They're not doing them any favors. Some of them are saying, I would not recommend this candidate for your program. They wouldn't be able to handle it. So just make sure you know who you're asking.
And talk to them. Don't just send an email and say, will you write a letter of recommendation? Here's the link. Say, okay, great. Can we talk, about my interest in being a PA? So you're selling it to them, and they're going to sell it in their letter, and then we're going to see it twice, right? We're going to see it in your personal statement and in that letter. Getting a lot of good inside tips today.
You were giving away a lot of tips.
I know.
You guys now have an edge for the next cycle.
And URI candidates are always successful. I mean,
they are
100% get in, but we have 3, 4, 5 in every class.
We definitely do. We've had URI candidates in every class since we started. And they go on to do great things. We love them.
Yeah,
Never
absolutely.
any trouble.
We love to hear it. Well, thank you so much, Katie. Thank you, Dr. Meehan, for this information. This is really helpful for all of our students, helpful for me as I learn a little bit more too. So I truly appreciate it. Thank you, everybody, for coming, for submitting your questions and for your attention, and we appreciate it. You can all find me through Handshake, or you can send me an email. And our website is uri.edu/prehealth, and all of this information about the JWU affiliation that we have is listed there, along with the timeline for you to check out. But more information to come as we get a little bit closer to the application opening. Thanks, everybody.
Thanks. We hope to see you on campus soon.
Yeah, have a good night.
Thank you.
Thank you.